All right, so those are injuries that happen as a result of not being frozen, but just getting cold. The chilblains, the immersion foot, trench foot, Raynaud's, those happen when your tissue hasn't frozen, it's just been exposed to cold. Let's go on to what actually happens when you actually freeze tissue. When you actually freeze tissue, you develop frostbite. That's the real definition of it. Now, there's frost nip, which is that very superficial layer of your skin gets down to freezing temperature. But frostbite itself occurs when you start to freeze skin and the tissue that's underneath it. And it comes basically, you can treat it as like a burn, sort of the same way a burn works in that you can have different gradings of it, and it sort of looks the same as a burn, all based on how deep the injury actually goes. So you can have first degree frostbite, second or third degree frostbite, and then a fourth degree frostbite. And also, like a burn, it can be hard to figure these things out right away, like what degree of frostbite they actually got, until the body has a chance to kind of warm up and demarcate, and then you can actually see what the effects are. But right away, it's sort of difficult to grade these things to start off with. How does frostbite happen? Well, again, tissue has to freeze. In order for our bodies to transfer heat or lose heat, we do it in four primary ways. So there's conduction, radiation, convection, and evaporation with sweat. Primarily, we're going to be looking at not so much radiation. Radiation is going to be kind of constant, but convection to some extent, but largely conduction is going to be the thing that we're going to see in the cold injuries and the freezing injuries. How fast do you get frostbite? How long do you actually have to be exposed? How long does it take a piece of tissue to freeze? Well, it depends on what that tissue is touching, because again, this is primarily going to be a conduction issue. So if you are exposed to gas, like air at normal pressure, it can take anywhere on the scale of like hours to freeze. So an hour, half an hour, something like that. It makes a little bit of difference on wind speed. We'll get to that in a second. Markedly different in that you can freeze your tissue in a matter of minutes if it's exposed to a cold liquid, especially like water. If you are exposed to something that transfers heat very quickly, like aluminum or copper or something like that, you could get frostbite. You could get tissue freezing in a matter of seconds, which you will see sometimes. So it could be, again, in the air, you're talking about minutes to hours, in liquids, minutes. If you're touching a metal, though, if you have your foot up against a piece of metal that's at 25 degrees Fahrenheit, it may freeze in just a few seconds, 30 seconds, something like that. And the colder, the faster it happens. Wind speed actually makes a big difference. So obviously, if you're traveling in gases, but the wind speed when you're out in the air makes a big difference. So when you get to these guys, a sort of mild wind, it may take 30 minutes to develop frostbite. If you get to the moderate wind or the colder temperature, something, wind blowing 25, 30 miles an hour, it may take 10 minutes. And if you get into the hurricane force winds, as you really start to get up there, 50, 60 miles an hour, which is possible in some, like Arctic storms and that sort of thing, then you may get frostbite in 5 minutes, even if it's, relatively warm outside as far as that goes. Probably not going to be relatively warm, but you get the idea. In terms of patient factors, the folks that get this tend to be males, tend to be drunk. Alcohol is probably one of the biggest factors in determining whether or not you are at risk for frostbite. The primary factor, the biggest way that you can tell if you are going to get frostbite or not, or your biggest risk factor, is if you've gotten frostbite before. What happens? How do you grade it? Why does it make a big difference how deep it goes? Because the deeper it goes, the more skin it kills off. So just like a burn, if you only affect the epithelium, then that would be like frost nip. If you only get the superficial layers, then you don't do too much damage. You don't get a lot of tissue loss and everything just grows back up underneath it. But as you go deeper and deeper down, as you freeze deeper tissues with more exposure, you can get down into the like neurovascular bundles. You can get down into muscle and bone and talk about real tissue loss at the end of the day. So just in terms of grading, when somebody's foot is frostbitten, it usually looks, kind of ignore this black thing. it's usually going to look something like this. You're going to see some degree of pallor. It's going to be kind of waxy and hard feeling. It's frozen. Maybe it's lost all its pliability. Usually, the person, once it gets numb, it stays numb. It's not particularly painful, but that can also set you up for increased trauma to it. In terms of the different grading, we'll hit those real quick here. So frost nip itself is, again, really superficial. It's just the superficial layer of skin that's, it won't cause real tissue damage later on. You won't get the blistering, you won't get tissue loss. And when you rewarm it, it turns red and it's painful, but then it goes away. You can get some edema that happens with it as well, as you see in this, like these somewhat puffier, more fingers than over here. Frostbite, the first initial stage of frostbite is when it gets down through the dermis itself. This usually, the hand turns red. It hurts when it happens, and then when it rethaws, starts to hurt quite a bit more. It's this intense burning type pain. Usually, it requires some degree of medication to take it, NSAIDs or something like that, because this is basically a burn. It's tissue destruction in the same way. So it's like a significantly painful first degree burn. But first degree will usually just kind of present with white or red, waxy, firm skin that gets much more red when you rewarm it. And here again, you can see that this was the person who walked between houses during a winter storm. She didn't have any way to cover her cheeks, and so she got first degree frostbite on her cheeks. When things get a little bit deeper, you start to get those, as we talked about in the very beginning in sort of the intro, those leaky capillaries that occur when you rewarm the tissue. So when you start getting blisters, then it's much like a burn, it's second degree frostbite. These are mostly the second degree in that they are clear or sort of milky fluid filled blisters. And also kind of worth noting here that these are all, these happen after you rewarm it. And usually takes about 24 hours to kind of develop to the extent that you're going to see it. You notice here some of these have a purple tinge to them. These are hemorrhagic blisters, meaning literally a little bit of blood is seeping out there because you're getting down towards the small blood vessels, the capillaries. And so you get a little bit of actual leakage of blood into the blisters. When you get hemorrhagic blisters, that tends to be third degree frostbite. More of what you see up here, the red fluid filled blister. And then this unfortunate person, terrible situation for him, was mugged, was intoxicated at the time, I believe, but was mugged and was left in a ditch for about 12 hours. They stole the person's shoes. So basically both feet got significant frostbite, as did their hands and their fingers. And this is early on, like when they first presented. You notice they look bad. But they still look identifiable as fingers. The feet look, terrible. It doesn't look like things are going to go well, but you can certainly see it. As time goes on, you get a couple of days into it, and you start to develop the blisters. You notice that in some places they don't actually blister very much because the tissue is mostly dead. This big white patch, much like a third degree burn, this is a dead area of skin essentially. So it will be insensate. It will be waxy feeling. It won't look like real human tissue itself. It's like a bad burn. And then as things go on, when you get maybe a month into it, you'll notice the eschar formation, the blackness that develops. You'll see some of these have actually come back a little bit. They're not looking great on this side, but at least they're, again, pinkish, a shade of red, but not mummified and ready to fall off in the same way that like the feet are, and these areas over the midfoot are in this person. So those are the grades of it. And that's mostly just informational for you, because we won't really be able to grade this stuff out in the field, generally speaking, because it's going to take, again, on the order of hours to days to figure out exactly how far into it the tissue destruction has actually occurred. But what do you do about it when you see it? The good news is that whether it's frost nip or whether it's fourth degree frostbite, you want to do basically the same thing for all of them, in that you want to get them warm. And you want to get them warm as rapidly as you safely can. That's really the key to it, no matter what it is. So melting the ice is of critical importance, getting that out of there, because every minute that the tissue's frozen is another minute that it's ischemic. The one thing that you don't want to happen, though, and the thing that if you are going to warm them, and you should, what you got to avoid happening, though, is this: the refreezing. Once they are warmed, once they get above 28 degrees Fahrenheit, you can't let them refreeze, because then the damage is, twofold, fourfold. It's multiplied out if you let frostbitten tissue get refrozen before it has completely healed. So you don't want that to happen. You wouldn't, in these cases, want to rewarm somebody if you couldn't pretty well guarantee that they were going to stay thawed. And so you may accept that he's going to continue to have frostbite. He's going to continue to stay frozen, because we can't guarantee that we can't refreeze. You've probably heard the idea, been told before, oh man, frostbite, you don't warm that back up. You don't put it in, don't hold it next to the fire or anything like that, which is probably a good idea. We'll talk about how to do it safely, but you go rub snow on it. Go rub it with snow to help warm it back up. That was popularized by one of the Frenchmen in Napoleon's army, his chief surgeon, Larrey, Jean-Dominique Larrey, who also incidentally came up with the idea of the ambulance and with the idea of triage. He also was the first to observe, or one of the ones to report anyway, that he noticed that after his soldiers who were marching in the middle of Russia in winter, when they would return to the campfire at the middle or after the battle at night, and their hands would like rewarm, they would get blisters on them. And so he figured, oh, okay, it must be the warming that's giving them the blisters. So don't warm them, just rub snow on them so that they warm up. And it actually didn't probably matter. They could have been some thermal injury, but it was that they had second-degree frostbite, not so much that they were probably getting horrible true thermal burns on it. So Larry is the one that sort of started spreading that nonsense around. Yeah, I thought it was funny. How do you warm them up safely? Well, you put them in warm water, and obviously not boiling water, not water on a stove, hopefully, but you want to immerse them in warm water of about 98 to 102 degrees Fahrenheit. Why 98 to 102? Because it's pretty close to body temperature. You want to immerse that part in a warm water bath that you can keep somewhere around, again, 98 to 102. That may involve you having to kind of change the water out, put warm water back into it. But that is a good way to do it. And again, you only want to do it if you can keep it warm. If you're out, 10 miles back on a trail, and the only way to get out of here is for that person to ski themselves out, then you don't probably want to make a fire and rewarm their foot entirely if their foot's going to get cold again in the meantime. It is best to rewarm these only if you can keep them warm. I think I've said that enough. And for most of us, that's not going to be a big deal. If it's an hour ride to the hospital, but it's a ride in a car or an ambulance, then yeah, absolutely. You can keep that warm. That you shouldn't have any problem keeping it above 32. But like I said, if you're back in the woods someplace and it may be a carryout or something, you may need to reconsider that. How should you do it? Again, pot of water somewhere around body temperature, 98 to 102 degrees. How do you know what that is? What you need to do as the rescuer or the healthcare provider is take your hand and put it in that water to verify. And you can't have frostbite either. It has to be a normal sensing hand. Put it in there and make sure you can hold it in there for 30 seconds without feeling that it is burning you, like literally being uncomfortable. It can be warm. I checked this out the other night. What's the temperature of 90? What does 98-degree water feel like? That feels like a bath when you put your hand in it and you go, oh man, that's a nice temperature. That feels really good, like nice and warm. If you were to say nice and warm, that's probably 98 degrees. If you put your hand in there and say, whew, that's a real warm bath, is the way I would describe it. That's about 102. If you put your hand in, you're like, oh my God, ooh, that's hot. Hot tub water is somewhere around, 108, 110, something like that. Hot tub water, you're starting to get a little too hot because you can actually develop thermal burns. So put your hand in and you want to say like, oh man, that is warm, nice warm water. That's about the appropriate temperature for them. So you take the person, you put their arm in there, or you put their hand in there, you put their foot in there, you tell them don't touch the sides because the sides can be a different temperature. Why do you use water though? though, specifically because water is all going to be about the same temperature. If water's 102 here, it's probably 102 here and here and here and here. And you don't get a whole lot of temperature variation within reason. Contrast that to like a forced air system, even air coming out of the heaters on your ambulance. This happens to be in front of a hair dryer, 195, an inch from the nozzle. If you move that away maybe 4 inches or so, it drops down to 152. And if you move it about 4 inches more beyond that, it's about 130 degrees, if not a little bit less. If you take and put a foot in between the thermometer and the hair dryer right there, the difference is almost, what is that, 70 degrees between the two. And whatever is close to the nozzle itself could actually get a thermal burn, while what's ever in the back may feel just fine. Keep in mind too that these folks are going to have insensitive, they're going to have numb fingers and numb toes. They're not going to be able to tell you if the water is too hot or if the air is too hot or not. So that's why you put your hand in there, and that's why you use liquids instead of gases. Because the liquids are so much more easy to, liquid is so much more easy to control. And again, the liquid to use is water. So the treatment for frostbite, rapid rewarming as soon as you can guarantee that it's going to stay warm. There's no benefit to letting tissue stay frozen if you're able to get it warm and keep it warm. That again is a problem. Say that you're doing a carry out and you have to drag this guy over 3 miles of snowy brush. His toes, even though you may have gotten them warm, you may not be able to keep them warm, even though you're going to keep him up out of the out of the snow. For the most part, they still may be exposed to the wind. If you're doing a lift or something like that, he might be exposed to the air and may not be completely covered. And so the chance of refreezing is certainly real, as well as the fact that most of our patients, when we're moving them around for them, are not going to be generating body heat on their own. And so the chance for hypothermia or for frostbite, even in areas that are not already frostbitten, just because we're pinning them down and keeping them in there, if their finger is exposed, like sticking out next to them, then they could certainly develop frostbite in those areas. Now, once you get them rewarmed, the treatment is going to be pretty much the same as burns, covered with a dry dressing, non-adherent pad, something like that. NSAIDs for pain, like 800 milligram ibuprofen, and then aloe, like out of the plant itself, is one of the recommended treatments for it. But that's, again, a little farther down the way. If you can get them warm and then cover them with dry dressings and give them some ibuprofen, that's pretty appropriate. Worth noting that there is some discussion about whether or not TPA is a good idea in these guys, and here's why. TPA, the same stroke drug. So the idea is that, again, if you have inflammation and stasis after they warm back up, that they can still have ischemia because they develop microvascular thrombi. Literally, they're clotted off. And here's angiograms. The picture on the left is before, and the picture on the left after in a bad frostbite case. You notice that before, there really doesn't seem to be a lot of vasculature out, in the toes themselves. They give them catheter-directed TPA. They go in with a catheter and kind of squirt it right where they want to squirt it. And the clots actually break up and they get good perfusion. Not everybody needs this. Not everybody's going to benefit from it. It really takes kind of a specialist to tell you if that is a thing that might be worthwhile. And then you got to have somebody that can actually do that. So a lot of times this only happens at like big tertiary centers and maybe not the place that you take the patient to initially, but they may get transferred on for something like this consideration of it. Because you can kind of see the difference. The picture on the right looks a lot more like a foot and not a bunch of nubs. So hopefully that person will do okay if you get it taken care of and get them open back up. Let's do some quick summary. Again, we can deal with heat. We can't deal with cold very well. Our only way to deal with cold is to not expose our actual body to cold. We don't acclimate to it very well. Even folks that live in cold climes don't acclimate to it very well, truly. Cold injuries can happen fast. They can take several minutes, or they can happen in the course of a couple of seconds, depending on, again, what you're exposed to. You want to keep your feet dry. You want to keep your patient's feet dry as much as possible. And again, giving somebody a clean set of shoes or a new pair of socks, even hospital type, goofy looking socks, can make a big difference for somebody just to be able to dry their feet off and keep them from getting immersion foot and those bad things. If you do have somebody that's frostbitten, you want to rapidly rewarm them with water that is about 100 degrees Fahrenheit or so. It's body temperature water, water that feels good to put your hand in, but not that you would say, man, that's kind of hot. And you want it usually takes about a half hour for that to happen. And you do not want that part to refreeze. So if you have thawed it out, it is incumbent upon you 100% to not let that freezing happen again. Because if you do, you're really going to hurt the person. They're going to be in bad shape. So that's what we've got on cold weather injuries that are not hypothermia. Hopefully, it's sort of interesting to you. It's sort of interesting to me. Check us out, emscurrentarounds.org, and we'll see you later.